Today, the topic under discussion is the allergic conjunctivitis. Now, there are a lot of allergens in our environment that can prove to be the cause under the conjunctivitis that is occurring to the patient. These allergens can range from pollen grains to the external foreign bodies, as well as it can be the dust particles that are causing this particular kind of conjunctivitis in the patient. Conjunctiva, as you all know, is the outermost and most interiorly placed, externally providing the protective layer towards the eyeball. So any inflammatory condition or any condition which proves to be infectious for the conjunctiva is going to result in this condition, which is known as the conjunctivitis in the patient. When you're dealing with the outpatient departments in the ophthalmology department, you usually come across patients who have this particular sign and symptoms of conjunctivitis. Specifically, if we look at the eye, in the normal position or in a normal patient, it would look like to be as such as shown in the diagram. And then if we have a patient of conjunctivitis, the eye would look quite irritated. The vessels would be enlarged and there would be visible signs of irritation in the eyeball of that individual. These signs would range from the redness and the inflammation that is occurring at the conjunctiva, as well as there will be a stringy, ropey discharge peculiar to the allergic conjunctivitis that would be present, and that can be seen when you examine the patient on the slit lamp. Now, this conjunctivitis, this inflammatory condition and the signs of irritation can be caused due to other factors as well. For example, it can be the bacteria causing the conjunctivitis. It can be the viruses causing the conjunctivitis. And when we go down the trail, it can be an allergic reaction that is giving way to this kind of an irritative picture in the conjunctiva of the patient. So how do you differentiate between a condition which is caused due to an allergen, which is caused due to any other pathogen, for example, bacteria or viruses? It's the discharge and the characteristics of discharge. When you look at the patient clinically, you'd observe that in cases of bacterial conjunctivitis, the discharge is usually more of mucopurulent nature rather than a thin, stringy discharge that is most characteristic of the allergic conditions. While in cases of viral conjunctivitis, it can be a much watery and a much thin discharge when we look at the patients of viral conjunctivitis. Rather, the inflammatory zone or the redness of the eye is sometimes so much that it gives the appearance of a hemorrhagic eye in cases of viral conjunctivitis. So basically, we weigh between the signs and symptoms of these allergic or these irritative properties that are given to the eye. For example, it is the redness of the eye, it is the characteristics of the discharge, it is the visual acuity, how much it is affected in this particular case of conjunctivitis, and this is how we are going to differentiate a particular case of allergic conjunctivitis from the various other causes of conjunctivitis which we've already discussed. So these inflammatory conditions can still occur in other conditions, but we'll weigh between these characteristics that occur in the inflamed conjunctiva, which has obviously these multiple causes, multiple causative factors. Even when we discuss the allergic conjunctivitis itself, it is divided into multiple types and it is classified into different categories depending upon the causation of the allergy in a particular patient. For instance, we have the vernal kind of allergic conjunctivitis, which is also known as or abbreviated as VKC. It's basically affecting the conjunctiva as well as the cornea in the patient. So it's abbreviated as a vernal keratoconjunctivitis, and it is a type of allergic conjunctivitis. Then secondly, we have atopic conjunctivitis, which is basically an adult form of vernal conjunctivitis. It's seasonal related, but it grows out into the adulthood, and that's why it's known as the atopic conjunctivitis in the patient. We have the giant papillary kind of conjunctivitis, which is caused due to the massive foreign bodies. For example, it can be sutures, the lenses. They can cause these different sorts of conjunctivitis, which are basically broadly categorized in the allergic kind of conjunctivitis cases. So this is the background knowledge towards the allergic conjunctivitis. When we are suspecting that this particular patient is suffering from allergic kind of conjunctivitis, we'd be looking for these particular clinical features, the signs and symptomatologies that basically move around with this allergic kind of conjunctivitis. Starting off, we have a simple allergic conjunctivitis, a case in which there is a simple allergen and it has its peculiar signs and symptoms that are related to this allergic kind of conjunctivitis. So this would be the typical picture of allergic conjunctivitis in a patient. There would be visible signs of allergy, the inflamed eyelids, the puffiness of the eyes, the redness of the conjunctiva, the inflamed vessels in the conjunctiva, and that stringy, ropey discharge that is present. They are all the characteristics or the clinical signs and symptoms that we're going to look for in this patient of simple allergic conjunctivitis. Then we have the seasonal allergic conjunctivitis. It's also named as the warm weather conjunctivitis, or it's sometimes termed as the spring catarrh conjunctivitis. These names were given due to the reason that usually on the interchange of the seasons, for example, when the spring season arrived, it usually came up with the exposure to the pollen grains. And sometimes this pollen was responsible for bringing out the allergic reactions in the patient. So that's why they were named accordingly. These allergic reactions were named the spring catarrh, or either in a lot of patients it was noted down that warm weather, specifically the hot and the humid weather, is responsible for bringing out this seasonal allergic conjunctivitis in the patients. So this humid environment is very favorable for a lot of organisms to grow in as well. So you'll have to exclude the allergic, the bacterial as well as the viral causes of the conjunctivitis when it is the case in which you're not sure whether it's the allergic conjunctivitis or whether it's the endemic viral conjunctivitis in which it spreads like an epidemic in a particular area. So usually the children are mostly more predisposed to the development of these kind of seasonal allergies, and it's quite predominantly known in the children. Usually they suffer from a lot of irritation in the eyes, a lot of watering of the eyes, specifically they would be complaining of photophobia, excessive watering, visual acuity is decreased in these patients, and they would complain of blurring of vision due to this kind of a seasonal kind of conjunctivitis in the patients. The seasonal allergic conjunctivitis, when we look at the etiology or the underlying factors that are responsible for the development of this seasonal changes in the environment, what are the triggering factors for the development of this seasonal allergic conjunctivitis? It's usually the seasonal allergies. For example, the trees, they sometimes produce a particular pollens or particular environmental changes that result in these allergic reactions in the patients. And only some of the people are predisposed to development of these or catching these environmental changes when there is a seasonal change. Similarly, we have the grass pollens that are sometimes responsible for these kind of allergic conjunctivitis cases. Then sometimes they're associated with allergic rhinitis. So patients who are already predisposed to the allergic rhinitis, may it be the pollen grains or the dust mites or it is the environmental changes, the temperature changes that are triggering a particular allergic reaction in a patient. These cases who are well-known cases of allergic rhinitis sometimes do develop this kind of allergic conjunctivitis as well with the passage of time. So then moving on, we have the perennial allergic conjunctivitis. Looking at the perennial allergens, they can be the house dust that sometimes predispose that particular person towards developing this kind of an allergic condition in a particular case. Then animal dander, so there are a lot of pets and a lot of animals that are kept in the house, and they can sometimes trigger an allergic reaction, resulting in the cases of perennial allergic conjunctivitis. Then obviously mites, bugs, it can be the lices, all of these even can trigger allergic reactions in children who are already lowered down in their immunity. It can be the elderly people, it can be the children. So it's basically the extremes of ages who are more predisposed to developing this kind of allergic reactions when they're exposed to dust, mites, or even the animal dander in their environment. The pathology would be a vascular response. So what do we mean by a vascular response? When there is an exposure to a particular kind of an antigen, there is an antigen-antibody response, and as a result of that, there is a vascular response that is triggered. Vascular response basically comprises of the vasodilatation and the increased permeability of the arteries and the venules that basically passes on the cellular infiltrates to the surroundings, and as a result, it basically ends up in a cellular reaction locally and causes the inflammatory condition in that particular person. We have a cellular response, all of the cells, it can be the histamines, it can be the mast cells, and they provide the histamines, and it can be the natural killer cells. All of them are basically migrated locally at the place of the cellular response. The conjunctival response occurs after that and after the exposure, and when there is a vascular response, the cellular infiltrates to reach the particular area, and as a result, the inflammatory conditions of the conjunctiva occur. The redness, the tearing, and the inflammatory condition of the eyes, as well as increased lacrimation, is a protective response towards the protective response of the eye towards any foreign body or any allergen that is the cause of irritation to the conjunctiva of the individual. Regarding the simple allergic conjunctivitis, when we just go through the pathology or the pathological basis of the allergic conjunctivitis, there is an initial contact with the allergen. The antibodies, there is an allergen and it comes in contact with the B cells. That is, we have the T cells and we have the B cells, we have the natural killer cells. These were the protective mechanisms of the body. So when this allergen, it comes in contact with the B cell, what happens is it also accumulates into the plasma cells, and as a result, there is a release of the IgE antibodies in the plasma. These are the mast cells, and we have the IgE receptors that are attached to these mast cells. Moreover, we have the subsequent contact with the allergen cell. And then finally, we have a granule formation inside these mast cells. After that, there is a release of histamine and leukotriene through these mast cells into the body. And as a result, after the outburst of this histamine and leukotriene in the blood, we have the allergic reaction kept in place in such conditions. The symptoms that are relating to the simple allergic conjunctivitis would include the watery, mucus, and stringy discharge that comes and that basically is complained of by the patient. Moreover, the patient would complain of intense itching and burning in the eyes. So these would be the particular clinical features or a clinical picture of a patient who comes up to you and you're suspecting that he's suffering from allergic conjunctivitis. He would complain of mild photophobia in the eyes as well. Photophobia, as we all know, is the uncomfortable feeling whenever the patient comes into intense light or even the sunlight causes discomfort in the eyes. So this would be the clinical picture of this particular patient. Now, what is the underlying pathology or what is happening at the conjunctival level when we say all of these symptoms are appearing? What would be happening at the conjunctival level? At the epithelium, the patient would basically experience a hyperplasia that is occurring at the epithelium of the conjunctiva. Then when we move on into the layers of the conjunctiva, after the epithelium, we have the adenoid layer, which contained the lymphatic tissue or the lymphoid or organs. So it's basically a cellular infiltration reaction that would occur at the level of the adenoid. And then comes the fibrous layer, and there we'd be experiencing the hyalinization of the fibrous layer of the conjunctiva. So this would be the complete picture of the conjunctiva whenever we'd be looking at the conjunctiva under the microscope. The epithelium, the adenoid layer, the fibrous layer, the conjunctival vessels, all of them would be affected whenever there would be an allergic reaction that is burst up in a particular patient. These signs would include a mild papillary reaction, and then it would also include chemosis, that is basically the encompassing or marking the irritation of the conjunctiva, and then there would be an edema of the lids that is marked as well, and as well as the patient would complain of, or you would be examining the hyperemia. All of these are the features that you'd be looking at or that you'd be finding whenever you ask the patient to sit besides you on a slit lamp and you're examining the patient closely. You'd be looking at the papillary reaction, the characteristics of the discharge, as well as the amount of the hyperemia or the congestion that is being caused by the allergic kind of conjunctivitis. It can be in the either the parts of the conjunctiva, either it can be the tarsal conjunctiva, the bulbar conjunctiva, or the palpebral portion of the conjunctiva that is involved in the hyperemic reaction of the allergic conjunctivitis cases. One should know how to diagnose these cases of simple allergic conjunctivitis. First of all and foremostly, we have the typical signs and symptoms. The clinical features of any disease are the mainstay for the diagnosis. Whenever we have to distinguish a particular case of allergic conjunctivitis, we should know what are the features we are looking at. Getting on to the definitive diagnosis is very interesting when you know how to eliminate the other diseases or the other confusing diseases that can be confused to the allergic conjunctivitis in a particular case. Normal conjunctival flora, so basically you will not be able to isolate any kind of virus, bacteria, or parasites in cases of allergic conjunctivitis. You basically carry on all these screening tests for tuberculosis, and even it can be the scleritis, episcleritis, cases of acute angle glaucomas, and then you have to basically distinguish this condition of allergic conjunctivitis from all of these conditions. Carrying out the culture tests for Staphylococcus aureus is very important over here, and obviously the tuberculous organisms are also going to be looked for. But in cases of allergic conjunctivitis, the patient would have a normal conjunctival flora. Then abundant eosinophils in the discharge will also be a definitive test or a conclusive test for signifying that this is a case of a peculiar allergic conjunctivitis that we're dealing with. Once you have confirmed that this patient is suffering or this particular patient is suffering from simple allergic conjunctivitis, there are different modes of treatments available. Primarily, we divide the modes of treatments whenever we are dealing with the allergic conjunctivitis into the drugs in which basically play a role in hindering down or hampering down the cellular reaction that is taking place. So this would be a group of drugs that would also contain the mast cell stabilizers, mild steroids, antihistamines. All of these would be included in that group. And then we have another group, which is basically the mucolytics and the lubricating drugs that can be used just to comfort the conjunctiva and hamper down the allergic reaction that is occurring at the conjunctiva. First of all, we'd be using the topical vasoconstrictors, and then obviously we'd be dealing with the artificial tears. This again is going to be modeled down into the group of the lubricating drugs that are used, or the mucolytic drugs that are used. Then we have the drugs that basically cause the desensitization of the conjunctiva, and again they are going to basically hamper down the cellular reaction that is taking place locally. We use steroid eye drops for such purpose. The elimination of allergen is the first and the foremost factor if it is a well-known allergen. And we have gone through the investigations and we have found that this particular allergen is causing allergy to a particular patient. We'd ask the patient to keep away from this particular allergen. Mast cell stabilizers and antihistamines are also prescribed again for the same purpose, to slow down the process of allergic reaction or the inflammatory reaction that is taking place. Now, as we've already mentioned, the simple cases of the allergic conjunctivitis, the simpler forms in which there are these particular features of conjunctivitis, the underlying causes or the allergens that are responsible for flaming down the inflammatory reaction in a particular patient. We have the vernal keratoconjunctivitis that is involving the cornea as well as involving the conjunctiva in this particular patient. So usually there would be a conjunctival irritation that is associated with the seasonal changes, with the environmental changes, specifically the hot and humid climates, as well as a seasonal catarrh or spring catarrh can flare up the reactions in cases of vernal keratoconjunctivitis. The conjunctiva, along with the cornea, is involved. We usually observe that there is a clumping phenomena that is occurring in the cornea of that particular individual, which is also known as gerontoxin. Gerontoxin is basically a terminology that is used for the corneal opacities that appear at the periphery, and it usually happens in the vernal kind of keratoconjunctivitis. So these are the particular terminologies when we are dealing with this kind or with this type of keratoconjunctivitis. The signs and symptoms would include the papillae and scars that are present under the lid, and obviously they are seen when we perform the eversion of the lid in these patients. The patient would have a very dry eye, which is also known as a phenomenon of xerosis that would happen in the patient. The corneal blood vessels and corneal scarring would occur for the patient, and usually there is a limbitis that is observed by the patient. That is an allergic reaction or an irritational phenomena that is occurring at the limbus. It is characterized as limbitis. The idiopathogenesis or the etiology is the antigen that basically releases the peptides, and that is basically responsible for the formation of the naive T cells. After that, the B cells are also sensitized, and there is the production of the IgE. Mast cells and basophils are involved, as well as there is a release of cytokines, leukotrienes, histamines, and chimeras into the blood. We have the Th1C cells that basically releases the gamma interferons, and we have the Th2 cells which releases the interleukin 4, 5, 6, 13, and 10. All of these are responsible for an acute and aggressive inflammatory response. All of these enzymes, coenzymes are responsible for the development of this allergic reaction or this inflammatory reaction to flare up in the individual. The predisposing factors would include the age of the individual. So usually they are more prevalent in the teenager group. Females are more predisposed to the development of this vernal keratoconjunctivitis. Climatic conditions or the environment is very important. It's more prevalent in the tropical environments rather than the temperate environments. Hot and humid climates are more favorable for the development of this vernal kind of keratoconjunctivitis. Season is again very important, sometimes related to the spring catarrh, and the patients who are suffering from spring catarrh, they usually come across this case of vernal keratoconjunctivitis. Females are more predominantly exposed to the development of vernal keratoconjunctivitis. The pathology would relate to the conjunctival epithelium. It basically undergoes hyperplasia whenever this inflammatory reaction is happening to the patient. The adenoid layer would be having a marked cellular infiltration. Moving on, we have a fibrous layer. We've already studied down the histology of the conjunctiva, and knowing the histology, we know that it has these four basic layers: the epithelium, the adenoid, the fibrous layer, and then we have the conjunctival vessels, which are lying at the innermost layer of the conjunctiva. The fibrous layer would show proliferation, and sometimes it would also show the hyalinization of the fibrous layer would occur over here. The conjunctival vessels would exhibit the increased permeability, and that is again responsible for the production of the allergic reaction in the patient. The clinical features would include the discharge and the heaviness of the lids, obviously, and there would be a mild photophobia, discomfort when the patient is exposed to light. There would be marked burning and itching, that is marking or that is highlighting the irritational phenomena that is occurring. And we have the release of histamines, we have the release of the interleukins and leukotrienes, and that is basically responsible for this allergic reaction and this itchiness that is occurring in the eyes. There would be an increased lacrimation that would happen, and that would be basically associated with the stringy discharge that is coming up to the eyes. The signs would include a palpebral form of conjunctivitis, lesions arranged in the cobblestone or the prevalent pavement stone phenomena. So it would be a picture that is quite beautifully exhibited over here, which basically is, as you can appreciate, it's a cobblestone appearance. It's resembling a cobblestone appearance, a pathway appearance. Then we have a bulbar or a limbal form in which we have gelatinous thickened accumulation and Horner-Trantas spots. Now, what are these Horner-Trantas spots? They basically occur at the cornea, and they're basically responsible for the deposition of the fat that basically highlights this Horner-Trantas spots appearance. The mixed form would be when we have the palpebral form as well as we have the limbal form. The combined features of palpebral and limbal forms would be sometimes exhibited in a lot of patients, and that would be basically the mixed form of vernal keratoconjunctivitis in the patients. The vernal keratopathy, that is when the cornea is involved, we'd be seeing the punctate epithelial keratitis, the ulcerative vernal keratitis, the vernal corneal plaques. So sometimes this hyalinization and all of this process of damage can mark the plaque formation in the patient. Subepithelial scarring, as well as the pseudo-geron toxon. Geron toxon, as you can appreciate in this particular diagram, it's basically the formation of this particular layer on the cornea. There would be this particular layer on the cornea that would be more towards the periphery, and it is marked as the formation of gerontoxin, and is usually as a result of allergic reaction that is occurring at the cornea or the conjunctiva of the patient. Regarding the differential diagnosis, we have to differentiate this condition of vernal keratoconjunctivitis from a list of other diseases, that is scleritis, episcleritis, tuberculous granulomas. We have the anterior body glaucomas. All of these have to be differentiated from this particular kind of condition of vernal keratoconjunctivitis. Trachoma with predominant papillary hypertrophy, for example, can be also confused with this kind of vernal keratoconjunctivitis. The mainstay for the treatment of vernal keratoconjunctivitis would be the steroids and the cyclosporins. So whether it is the treatment of the complications, either it is the treatment of the major signs and symptoms of vernal keratoconjunctivitis, the treatment would include dealing with steroids and cyclosporins. Artificial tears, obviously, they are basically dealt in with whenever we are using these agents for mucolytic or lubricating purposes. The artificial tears, which are basically composed of the carboxymethyl cellulose, they will be prescribed to the patient. Acetylcysteine, that is almost 0.5% that can be used topically for the patient. Oral histaminics, they are used for the relief from itching. Oral steroids for a short duration of time to hamper down the inflammatory reaction. We have a large papillae treatment, which is basically dealing with the surgery. We have to deal it with surgeries, and on the other hand, we can also imply the cryo application, the laser applications, the steroidal injections. Usually, these steroidal injections are given subtarsally to the patient. So this would be the treatment, the mainstay or the major points of treatment whenever we are dealing with the large papilla. On the other hand, we have the vernal keratopathy that has to be treated. So we'll be using steroids for that purpose, surgery, and we'll be also performing superficial keratectomy in these patients of vernal keratopathy, in which the cornea is also involved. We can perform lasers, surgeries, steroids, or keratectomies for these patients in which there is a complication, in which there is keratitis, corneal ulcers, gerontoxins, whatever the complication is, we can treat that by these methods. We'd advise the patient to use goggles for photophobias, ice packs just to hamper down the inflammatory reaction. Change the area, a change in the environment. If it's the hot and the humid environment that is responsible for flaring up this inflammatory reaction, we have to change the area of the patient. Cold compresses are very important over here, and obviously the desensitization of the patient is sometimes a procedure of choice when these allergic reactions are not hampered down by other ways. We have atopic keratoconjunctivitis on the other hand. What is atopic keratoconjunctivitis? It's basically an adult form of vernal keratoconjunctivitis through which the patient grows out, and it's usually more prevalent in the 4th or the 5th decade of life. The pathogenesis behind the atopic keratoconjunctivitis is the IgE and the cellular immune mechanisms that come into play over here. Then basically it's the type 1 and the type 4 hypersensitivity reactions. The inflammatory changes of the conjunctiva and the cornea, they also occur at this point. The symptoms over here are the itching and the soreness of the eyes, as well as it can be a mucoid discharge or the xerosis of the eyes, which is basically marked by the dryness that is noted down in the eyes. Photophobia or a blurred vision is also one of the major complaints that the patient would be registering to the ophthalmologist. The signs that we'd be looking for are the eyelid signs, first of all. That would basically include the lid margins and the Hertog's sign. Hertog's sign is basically the lid inflammation that occurs in this particular case of atopic conjunctivitis. Then we have the Denny-Morgan's folds, and these are the particular folds that are present on the palpebral part of the conjunctiva. The conjunctival signs would include the tarsal or the bulbar conjunctiva, as well as it can also include the inflammatory reactions, the papillary reactions that occur at the limbal part of the conjunctiva. The signs at the cornea would include the punctate epithelial erosions, and it can also be the plaques and the epithelial defects. Associations with the keratoconus, it can be the complications that occur in this particular case of atopic keratoconjunctivitis. It can be even the retinal detachment that it ends up in, or either it can be the atopic cataract that occurs in these patients for atopic reasons. The treatment would be you should prescribe the patient with oral NSAIDs and antihistamines, antibiotics, application of steroids, antibiotic eye treatments, and then we'd be basically prescribing the patient for the other associated features, for example, the use of goggles for the photophobia, and the other complementary prescriptions would be given. Moving on, we have another variety, which is known as the giant papillary conjunctivitis. The etiology for this kind of a conjunctivitis is the contact lens or the prosthesis that is used by the patient, nylon sutures and scleral buckling, plastic leached out by the tears. So these can be the triggering factors in this case of giant papillary conjunctivitis. The clinical features would include the itchiness, the stringy discharge, and the patient would also complain of reduced wearing time of lenses. We'd be experiencing the less wearing of prosthetic shell or hyperemia that is observed by the patient, and then the papillary hypertrophy, that is one of the important signs that we're looking for whenever we are suspecting the giant papillary conjunctivitis. For this giant papillary kind of conjunctivitis, it basically includes the removal of causes. It can be any triggering factor. Either it can be the contact lenses or the use of prosthesis or the scleral buckle that is used by the patient, which is triggering this allergic reaction, should be removed. Contact lens or artificial eye, and then the mast cell stabilizers, for example, the sodium chromoglycate is advised or prescribed to the patient. Antihistamines, for example, they combined with the mast cell stabilizers in these cases, and steroids are also coupled up along with these antihistamines and the mast cell stabilizers, which basically are given to the patient who are resistant to this typical kind of treatment, that is the use of sodium chromoglycate and mast cell stabilizers. If they're unresponsive to this kind of a treatment, we'd be giving it a try with the combination of steroids. Phlyctenular conjunctivitis is one of the varieties which is due to the innate antibodies of the individual. It's basically more prevalent in patients who are malnourished and underweight, and they're more prone to the development of this kind of keratoconjunctivitis. The etiology behind this kind of phlyctenular keratoconjunctivitis, the causative allergens over here are the proteins of Moraxella axonfield, Staphylococcus proteins, tuberculous proteins. The predisposing factors would be the season as well as the living conditions. Now, what do we mean by the living conditions? Usually the patient who would come up to you and you are suspecting this kind of phlyctenular conjunctivitis, it would be a female. Usually the age group would be 3 to 15 years old. a malnourished, underweight child, as well as he'd be living in an overcrowded or an area or the environment which has poor ventilation. So these would be the predisposing factors whenever you come up with this kind of a patient. Living conditions would be congested. There would be an undernourishment that is observed in the child. Age and gender is very important. Females are predisposed, as well as the age group, the younger age group, that is almost 5 to 15 years of old age group, is more predisposed to the development of this phlyctenular conjunctivitis. The pathology regarding this kind of a conjunctivitis, first of all, we have a nodule formation stage, which goes on to the stage of ulceration. There are the ranges of ulceration that can occur in such a patient, ranging from the fascicular ulcerations, ranging from the miliary ulcerations. They're large in numbers, small in size. So these are the different sorts of ulcerations that can occur. As well as the stage of granulation, it surpasses the stage of ulceration, and then we have the stage of healing in these patients. So then it goes on that it's a whole ulcerative and an allergic reaction that is going on in a patient. The clinical features would include a simple phlyctenular conjunctivitis, miliary phlyctenular conjunctivitis, including the small-sized miliary ulcers, multiple ulcers, ulcerative phlyctenular keratitis, necrotizing phlyctenular conjunctivitis, as well as we have the diffuse infiltrative phlyctenular keratitis on the other hand. Moving on, the differential diagnosis, we have to differentiate this particular condition from episcleritis. We have scleritis, and then we have the conjunctival foreign body granulomas that we have to differentiate it from. And obviously, this differentiation depends upon the cytology, upon the microscopic examination, and then performing the stool culture examination for the parasites. So all of these are very important whenever you are differentially diagnosing this particular patient. The management would include the local therapy with topical steroids or antibody drops, atropine eye ointments, specific therapies including to exclude the tuberculous infections, septic focus, and parasitic infection elimination, and general measures upon high protein diet. Supplements of vitamin A, B, and C are also prescribed to the patient. Finally, we have the contact dermatoconjunctivitis. What is basically happening over here is that there is a prolonged contact with chemicals and drugs, and that is basically, it can be the medications like atropine, penicillin, and neomycin, and they're responsible for the production of this kind of conjunctivitis. The clinical features would include cutaneous involvement, weeping or eczematous reaction, conjunctival response, which is marked by the hyperemia with papillary response, and cornea has a punctate epithelial keratitis. It can lead to ulcerations. It can lead to granulomatous formations as well if the inflammatory process goes on in this particular patient. The diagnosis would include a typical clinical feature, lymphocytic response with many eosinophils, and a positive skin test for the contact dermatoconjunctivitis would finally give a definitive diagnosis to this condition. The treatment would include discontinuation of the causative medication and a typical steroid eye drops, and the application of the steroidal ointments for these patients. So in this lecture, basically, we discussed the different allergic kind of conjunctivitis cases. There is a variety of categorization to this allergic conjunctivitis, ranging from the vernal variety. We have the seasonal variety, the atopic variety, the giant papillary conjunctivitis, which is due to the foreign bodies, as well as we have the phlyctenular kind of conjunctivitis. Dealing with these vast range of conjunctivitis cases which are allergic in their origin, and how do you differentially diagnose these cases is very important, and remembering their signs and symptoms. The clinical picture of these cases is very significant in this case. So that is the end of this lecture. Thank you for watching sqadia.com.